Did everybody, somebody has heard about eclampsia before?
Yeah, I have.
Okay. All right. So preeclampsia is actually a risk for seizures. Okay. So that is the main risk for this preeclampsia. I said risk. Okay. And these seizures mostly happen in very young women, fertile age, or very advanced age. Advanced age doesn't mean 70 years old, 60 years old. It's just 35, 40 years old. So that is an advanced age for fertile age women. So preeclampsia is going to be called, and that is RDMS, or called toxemia. Toxemia, don't forget that. I didn't say toxoplasmosis or something. That is totally different. Toxemia. And when they actually get worse, the preeclampsia is pre of what? Pre of the eclampsia. So when you have eclampsia, that means that you have seizures. That is the moment that you have seizures. When you have preeclampsia, that is going to be actually risk for seizures. Okay? All right, so that is number one. So the definition of the word preeclampsia or toxemia, and the word eclampsia. Eclampsia when the patient is already having seizures. So what are the characteristics of this preeclampsia? The preeclampsia basically is going to start with hypertension. Hypertension. We have hypertension. And this hypertension, be careful with that, because you need to go to the clinical history, because is this hypertension was from the past or is coming from the pregnancy, right? So basically, you asking the patient, you taking medicine, basically it's a young woman, most likely she is not suffering for hypertension, right? So basically the hypertension, but you need to ask, are going to start during the pregnancy. When is going to start the hypertension? In about 20 weeks. 20 weeks of gestation. 20 weeks of gestation. Question for the exam. Okay, so what is vasospasm? Vasospasm is, for your anatomy, physiology, you know that your blood pressure is equal the cardiac output times by the peripheral resistance. If you have vasospasm, that is similar to, say, vasoconstriction, peripheral resistance go up, and the blood pressure go up again in this case. Okay, all right. So conclusion here, the hypertension. So you need, as sonographer, you need to do some clinical assessment, some small clinical assessment that is basically in the clinical history. Okay, otherwise you're going to miss it. Okay, all right. So that is a 20 weeks of gestation where the high blood pressure start to increase. In the past, this woman didn't have any problem. So I have many patients with preeclampsia in the past. They turn into eclampsia. Very well, many stories about that. 19-year-old women actually first pregnancy, not necessarily should be first pregnancy, and start to have hypertension in about 20 weeks of gestational age. Okay, so just to remember. In addition to this, we have a triad. We have three things that are going to be a companion with the preeclampsia. Number one, you already know, is the hypertension. Number two is going to be edemas in lower extremities. Edemas in lower extremities. So you see that the legs are going to, the patient start to feel that their feet are hot. They're hot. They cannot stand it. So they actually, what we need to do is to elevate the legs. Elevate the legs. So at least three times per day for 15 to 20 minutes. 15 to 20 minutes. Okay, so you cannot do anything about that. They are going to receive some treatment that we are going to talk a little bit, touch a little bit. And we have hypertension, edemas in the lower. Imagine a patient with edemas in the lower extremities. And number 3 is always asking in RDMS is the proteinuria. 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 What is proteinuria? Somebody can tell me what is proteinuria?
Would that be like protein in your urine when they do like a dip?
Exactly. So you are a sonographer and you want to check if this patient has proteinuria. You need to go to the lab test, basically. And what they are going to do is the collection, to take that collection of urine in 24 hours. If the content of proteins in this volume in 24 hours is 3 grams or more, that means it's proteinuria. Proteinuria. I'm not going to go into more pathophysiology because proteinuria is the one who is going to contribute basically to the edemas in the lower extremities, because proteins are going to hold the water in the arteries and veins. If you don't have proteins, the water cannot be held in the vascular space, so they can escape and they go to the lower extremities. Why lower extremities? Why? Because that is by gravity, the waters go to the center, right? To the, down. So that is where it's mostly located in the lower extremities feet. Since this preeclampsia doesn't end with the delivery, they can actually be even one month and a half after the delivery. Okay? All right, so here we are going to see that it's clinically defined by hypertension and proteinuria. Proteinuria. For this, what is going to happen with the placenta? From previous classes, we talk about the placenta thickness, right? And the placenta thickness, so I will tell you this. What happened with an organ? What happened with an organ when the vessel is this size? So it's receiving blood supply from this. Okay? So this is the volume of blood that is receiving by the organ, correct? That is normal. But what happened in a hypertension? How much is going to be the volume? It's because it's vasospasm. Vasospasm is the same to say vasoconstriction. And when you have to the organ, it's going to be low levels of oxygen, very low levels of oxygen, right? So any structure can develop because we need oxygen for the metabolic reactions to create tissue. And if we don't have oxygen, the placenta starts to get more thinner. It's not going to develop properly. So we have a thin placenta. Okay, we got it? So if you have a thin placenta, so you have your Doppler, right? You have your Doppler, and what you're going to check? You need to check the uterine artery. If the uterine artery is not is having high resistance, you need to check the umbilical cord, right? Umbilical cord, and to see if there is actually the high resistance or low resistance. You know that the uterine artery and the umbilical cord, as they go more advanced in pregnancy, we have lower resistance index. Okay? All right? All right, so preeclampsia, systolic pressure of more than 140 and more than 90 in the diastolic pressure, in 2 occasions at least 4 hours apart in previous normotensive patient. So that is going to be making the early diagnosis of preeclampsia. Okay, so in hypertension we have the normal blood pressure is 120/80. We have the pre-hypertensive. All right, so this is going to be less than 139 and less than 90. Right? We have actually the stage 1 and stage 2. Stage 2 is when it's more than 160, over 110, and 100 diastolic, and stage 1 is in between. So I'm not going to go in detail this, even if you want me to do it, I can do it later, but definitely, yeah. So I want you to remember that we have here the stage 1 is going to be 140, see, 140, and more than 90. Got it? Equal or 140 and 190. So that is a stage 1. So that is the value of pressure that you're going to see in this type of patients, okay? All right, so we okay with that? And one more thing, when you're taking, well, you're not going to take blood pressure, it's going to be in the report. Okay? All right, so what we are going to do is assess the status of the fetus, and as well as evaluate for IUGR, intrauterine growth restriction. This is actually from the, not from the very beginning, right? It's about 20 weeks where you start to have deficit of oxygen. So basically, they are going to be asymmetrical. See? It's going to be asymmetrical IUGR. We okay with that? You already know what is the importance of the abdominal circumference. What is the most important measurement in the third trimester for growth? Is going to be the abdominal circumference. Don't forget that. The most important in the second trimester is going to be the BPD. BPD. No, the head circumference is the BPD. All right, so when you have this problem, so now I want you to see the over the panoramic view. You have a patient who has preeclampsia. Imagine coming to your office right now. I say, well, this patient has preeclampsia. So you're going to scan the patient. It can be a scanning for the first trimester, second trimester, third trimester, growth, anatomy, or whatever, right? Date. But dates is not going to, it's completely normal. So the patient is 22 weeks, let's put it this way, and the patient starts to have higher elevation of pressure. And how do you adjust your protocol? So your protocol is not going to be just the anatomy. So in this case, you need to be focused on what? You can tell me. The umbilical artery, Doppler, to know the well-being of the fetus. You can check the uterine artery too. The uterine artery. Okay, the uterine artery. By the way, for the exams and all that, you already should know all the branches of the uterine artery. Okay, the arcuate, the radial, the straight, and the spiral. Okay, all right. Okay, let's talk about AIDS. Can somebody tell me what is the difference between a patient with HIV and AIDS? Somebody, or is the same? Or is different? Or what do you think?
No, they're different. I just forget what differentiates them.
Okay, so the way to differentiate them is actually clinical. Very simple. A patient with HIV, patient with when you said just HIV infected, that means that the patient have the virus without signs and symptoms. There is no signs and symptoms. HIV. But the autoimmune deficiency disorder is going to be, or syndrome, this is going to be with signs and symptoms. So AIDS is infected with HIV. But the difference is this patient with HIV are going to start showing signs and symptoms. And that is taking about 7 to 10 years. After you get infected, it's going to pass 7 to 10 years where the CD4 and the lymphocytes helper of the immune system start to go down and down and down and down and down. The immune system starts so down that you start to have risk for infections. And that is when the patient starts to show signs and symptoms. One of the first signs and symptoms are going to be, for example, repetitive respiratory infections. Okay, so that is make you suspicious of that. All right, so we got that.
Thank you for the explanation. I think Dr. Mania explained this already. So that's perfect that we are reviewing it.
Okay, thank you, Ms. Mania, too. Okay, how many cases we have of HIV? Just to make it closer here, we have 150 cases, new cases, in a year only in San Francisco. For this, multiply by 4, those are who doesn't know that they have HIV. Okay? All right, so we got that. Okay, so we have about 600 patients who doesn't know they have HIV walking around San Francisco. Yes? A question coming?
Hold on. Question, please. As regards the HIV, the AIDS that you just said, and you said respiratory infection is the sign and symptom.
Yeah.
Is there any correlation between that and the number of deaths that they're having with the coronavirus?
Oh, so well, it's carried a little bit. You are asking me if the HIV have some relation with the coronavirus?
No, I'm talking about the high number of death rate in the US.
The what?
From other countries. If the HIV and AIDS is also a factor.
Oh, to have. Oh, yeah. Okay. All right. So I think I got to your question. So you're telling me a patient who has HIV has a precondition, right? It's considered a precondition in order to have increased the risk for coronavirus, right? Right? That is your question? Okay, so I don't hear you, Ms. Olan, but okay. So if that is the question, yes, the answer is yes. So HIV, what it's going to do is to deplete your T helpers. What are T helpers? T helpers are lymphocytes that are going to be the commanders to. It's like let's put it this way: is the special forces of the army to fight against the enemy. Okay, so those are the ones who are being killed by the HIV. And obviously, if this immune system is depleted, not only for COVID-19, but for any other disease, could be viral or could be bacterial or could be fungal infections. So immune system is going to be very, very, very much hurt or damaged. Okay, so questions here. HIV can pass the placenta barrier. How the patients can get HIV? A fetus can have HIV. Okay, and the answer is yes. Okay, but it's very low percentage. Basically, from the 100%, of all the new borns that have contact with HIV, 99% are going to happen during the delivery. So the placenta somehow is going to block the passage of the virus through to the fetus. That is variable according to how much the mother is going to control the viremia. Viremia means how much virus you have in blood. So that viremia is going to be controlled by some antiretrovirals, and if you control that, most likely the baby will not have any problem during the pregnancy and even the delivery. Basically, we do C-sections here in order to prevent contact with the blood during the delivery. The 1%, and it's less than 1%, because the mother didn't control the levels of virus, they can pass to the placenta and affect the baby. This baby is unfortunately affected with HIV, and this is a magazine that anyhow. And what happened with the HIV in the fetus? They are going to have they're going to have some characteristics of the face, dysmorphic face. All right, dysmorphic face. Basically, they have a bulging head, so very pronounced forehead, very pronounced forehead. They have some problems with getting closer the eyes to the center, hypothyroidism, but basically those are what we call dysmorphic features. Then in ultrasound, we are not going to detect. Okay, we are not going to detect. It's very difficult to detect HIV or AIDS just doing ultrasound. Okay, transplacental infections mostly can happen in early pregnancies, and that depends on how much viremia, how much mother is controlling the levels of the number of viruses in the blood circulation. Okay, so transmission of HIV to the fetus is about 1%, less than 1%, and so from the 99% are going to be passing from the mothers at the time of that delivery. So delivery, that is the time. So you know that the mother do not share blood, do not share blood with the baby, right? With the baby. And the baby is producing his own red blood cells, and the mother produces her own red blood cells. There is no mixing. No mixed blood. The only time that they're going to mix blood is at the time of the delivery. They're going to mix. There are several studies about that they mix about 2 cc. So that means 40 drops of blood. Enough in order to increase the risk for the pass the virus to the fetus. Okay? All right. In ultrasound diagnosis, you have actually a different, this is HIV in fetus, fetal demise, intrauterine growth restriction. This depends. It can be symmetrical or asymmetrical. If that is happening at a very early stage, mostly it's going to be a symmetrical what? IUER. But this is not happening in advanced gestational time. They are going to be asymmetrical. Okay, so microcephaly, we have craniofacial abnormalities. We have here prominent forehead, as I mentioned, lateral bossing, hyperthyroidism. So I said hypo is hyperthyroidism, sorry, flat nasal bridge, and short nose. So those are the characteristics of the fetus. Risk factors: severity of maternal disease, high viral load, means viremia. Viremia is a term that you're going to hear a lot. Viremia is the amount of virus. Emia means blood. The amount of virus in blood is the viral load. So we have the maternal CD4. Those are the helpers. I'm not going to go on that because it's not needed at least for this purpose. Okay. Oh, by the way, what is PROM? PROM. Guys, you are PROM? You consider yourself your group PROM? Yes? Okay, silent. All right, what's PROM? PROM, come on, let's go. Advanced OB. PROM. What is PROM? PROM 2000. Which PROM are you going to be?
It is related
to
the rupture of the
membrane. Premature rupture of the membrane.
Excellent, Olan. Thank you. To premature rupture of membranes. Which membranes are broken? If you have premature rupture of membrane, which membrane is the one who is broken? The amniotic membrane. Is when you see the fountain is broken, so that is a premature rupture of membrane. Why is called premature? Because you don't want this fountain of amniotic fluid that is helping the baby to grow, right? Especially in the third trimester, right? They are going to be if the amniotic fluid is broken, it's not there. So there is no space to grow. So the baby starts to have some problems, right? So especially to develop the thoracic cavity, so to develop properly lungs. So that is important, the premature rupture of membrane. So at the time you're going to deliver, you have the rupture of the membranes. That is actually helping to induce the delivery. But if you have premature rupture of membrane, that is means at 37 weeks, 36 weeks or less, that is a very high risk of the patient. Okay, fetal alcohol syndrome. How many, what drink you like? Lately, I'm taking, well, okay. I drink, I have a collection of wines and other spirits, but it's just decoration. I don't take it. But fetal alcohol syndrome. Fetal alcohol syndrome is no, actually in the past they were saying that 1 or 2 glasses of wine during the pregnancy, and that is for your, for your knowledge, for your own knowledge, for whatever is that. So don't take alcohol. In the past, they were saying 1 to 2 glasses of wine during the week, and now that is not actually the latest studies in the JAMA in 2019, they said that actually even 1 glass of alcohol, anything, what it's doing is to delay the reproduction of nerve cells in the fetus. So if you take 1 glass of any alcohol, that is going to delay the reproduction of the nerves, the number of nerve cells that are going to born. So literally, you are taking to the baby some neurons. So what you want is a full potential to obtain the whole potential of the baby at delivery, correct? So that's why in the past I was telling my patients you can take 1 or 2, but now no, I will say not alcohol at all. Okay, I don't want not even miss 1 cell of that nervous system of the baby. Okay, so in addition to that, mothers, there's people who are alcoholic. Okay, so and you can tell what are the consequences of that after delivery. Fetal alcohol syndrome is called FAS, fetal alcohol syndrome. This fetal alcohol syndrome, when the mother is getting drunk, the baby is getting drunk too. Both are getting drunk. Okay? The mother have habitually taking alcohol at the time of delivery. The baby start to who is going to give alcohol? There is no buttermilk that give you alcohol, right? But actually what happened, the baby start to be addictive. And they have actually the some how you call that addiction. They have like with X. Who said that?
Danielle.
Withdrawal. Daniel, thank you so much. Withdrawal syndrome. So the baby is having withdrawal syndrome. Withdrawal syndrome, we have physical addiction, physical dependence. And with physical dependence, you cannot do too much. You start to sweat. The baby starts to sweat. The baby starts to increase temperature. The baby starts to have seizures. Okay? And that is what we call withdrawal syndrome. So the mother is giving to the baby withdrawal syndrome. In this case, you already know, you can tell that it's going to be IUGR because the cells are not reproducing, right? They are going to be actually, mobility is going to be slow, the heart rate is going, everything is slow down in the fetal alcohol syndrome. Okay, so yeah, so when they're born, the baby is going to have these seizures in 1 to 3 days. 1 to 3 days. So that they need to sedate the patient with diazepam, etc., treatments. And actually, the baby, what is going to happen? They're going to have all right, so this is the past. So I will take this if only one. So I will consider not to take alcohol at all, not even 1 glass. Okay? So in order to keep the number of nerve cells. So I need to update this. This is slide that was updated. I need to update it for this year. Okay? Okay. All right, so the alcohol, what it's going to do is metabolize, and they're going to pass the placenta. So they're not going to be detoxified by the fetal liver. Right, so this is important. You know why? Because the fetal liver is not mature yet. So they cannot metabolize as an adult. So the effect is going to be like 1 in the mother, but it's going to be like a 3 or 4 effect on the fetus. So that is what you need to remember about that. So the characteristics of fetal alcohol syndrome, we have microcephaly, a small head, microcephaly, micrognathia. What is micrognathia? What is micrognathia?
Is that like the mouth area?
Like small chin.
Receding chin, yes.
Yeah. Okay.
It's going to be a small chin.
Yeah.
Excellent. Microphthalmia, small eyes. And you can see that in the street. Do you notice that? A patient coming from mother who were alcoholic, they are going to, let me see like that. And there's another face there. So what happened is the philtrum. You know what is philtrum? The philtrum is what is under your nose, here. 2 lines. Do you see that? Oh, well, in this patient, you don't have it. But everybody have that, right? Or mostly all of you, right? Everybody. This philtrum, these 2 lines disappear. It's totally flat. It's totally flat, the upper lip. These kids are going to have his behavior are going to be very, very aggressive. They cannot adapt to any situation. They're always having problems in the school. And because of this mental activity is being altered, mental retardation. The mental retardation, that students are going to be very difficult to accept new environments, new classmates, let's put it that way. So always there's to be in troubles. Okay? All right, so in RDMS, they are going to ask you preeclampsia, by sure. They're actually mentioned, probably, they are going to mention the philtrum. The philtrum. Don't overlook the philtrum, okay? Philtrum. There's no philtrum in patient who has this. You cannot recognize this in ultrasound only just after birth. One thing is microcephaly. So microcephaly is small heads, right? Small heads. The fetal cytomegalovirus. Fetal cytomegalovirus. This is a very bad guy. Mostly they are going to be where you put your kids, the kids in the nursery, or how you call that? When you put daycare, right? Daycare.
Yeah.
Daycare. So be careful to go to the daycare if you're pregnant. Okay? Be careful. Okay? Why? Because the fetal cytomegalovirus is a virus, as you can tell, that produces signs and symptoms of a cold, simple cold. And this simple cold is normal probably in kids, right? And if you go to a daycare and you kiss the baby because it's called the kiss disease, there is other variant that is called the mononucleosis, that is I'm not going to talk about that because it's not the purpose. So this is, they can be transmitted by simple kiss. That's why it's called the kiss disease. All right, so going to the point, what is the consequence to the fetus if the mother has cytomegalovirus? The mother is going to have like a simple cold. She didn't realize she was infected with cytomegalovirus. And this cytomegalovirus produced three things. I told you this before. Somebody can tell me? Some help me here?
Could you repeat the question, doctor?
Okay, so what are the consequences of cytomegalovirus in the fetus?
Brain damage?
So that means, one, mental retardation. What else?
Cardiac?
Blindness, no cardiac. And deafness. You want more? Enough, right? Enough. You can do this just preventing to go to crowded areas or with a lot of daycare kids that are having viruses everywhere. Okay, for this, the one I want you to remember is this mnemonic, and that's what I was trying you to, or somebody to tell me, is torch. Remember torch? Somebody remember torch? Torch, torch, torch. What is TO? This is RDMS, huh? Don't tell me that is because I like it. No, it's RDMS. Torch is RDMS, 100%. Torch.
Is
Toxoplasma
toxoplasmosis?
Gondii, yes. That is actually in the litter of the cats. Okay, so if you need to clean the litter every day, twice a day, right? Because the feces this protozoa is located in the feces. When the feces are getting dry, and when some wind is coming, the spores of the toxoplasm is flying on the air, and then you can inhale with your nose, right? And that is where it's coming, the toxoplasma in your body. This toxoplasmosis do the same thing that the cytomegalovirus. TO. R. What is R? R is the rubella. You have your vaccine MNR, right? So the rubella. What is doing the rubella? Rubella have the same things of the blindness, deafness, and mental retardation. What is C? C is the cytomegalovirus. And what is H is the herpes. All of them are going to have this problem: mental retardation, blindness, and deafness. What they are going to ask you in RDMS is this: torch. What does it mean, torch? So torch are actually a medical indication for termination of the pregnancy. Pregnancy termination. Terminate the pregnancy. Okay, we got that?
Yes.
Okay, so here we have when you have a viral infection. All right, so they are going to pass through the placenta. Placenta transmission. Obviously, in order to this is not difficult to remember. Is the baby is affected by the cytomegalovirus, how it's come? They need to pass through the placenta, right? So that is the transplacental transmission, characterized by eye drops, ascites, and ventriculomegaly. Okay, I'm going to get you here. All right, so which one you want to start with? Eye drops, ascites, or ventriculomegaly? Let's start with the easy one, is the ascites. What is ascites?
Accumulation of fluid.
Where, Mario?
This is Lourdes.
Oh, Lourdes, sorry.
It's usually in the peritoneum or around the organs when there's when there's trauma or inflammation in the
In the
abdomen.
abdomen. That is ascites. Don't forget that, please. Okay, ascites is going. Ascites, where you see ascites, you already pass what is abdomen, right? So ascites you will see where in cirrhosis. Where you see what else? In portal vein hypertension. Portal vein hypertension. Right? Heart failure. So those are things that you should know from already from your abdomen. So ascites,
Cirrhosis, right, doctor?
sorry?
In cirrhosis as well.
Cirrhosis, yes. Cirrhosis.
Oh, sorry, you
Yeah,
said that.
cirrhosis. So here we have ascites, and ascites is accumulation of fluid in the abdomen. So imagine, scan the baby, and you will see the amount of fluid in the abdomen. What, in your measurement, what is going to change? What is going to be different if you make the measurements? The abdominal circumference, right? Abdominal circumference is going to give you more age than the week that's supposed to have the baby. That is ascites. Now, what is eye drops?
Is accumulation, but it has to be more generalized or more than in one place, I think.
Yes, it's going to be 2 or more places. So you have ascites, and you have, for example, pleural effusion, or you have pericardial effusion around the heart, around the lungs, or in the brain, or any part of the body. That is called eye drops. Okay, so this is extremely important. You know why? Because eye drops is an indicator of infection. But they said, oh, but just wait a minute, infection? But you said Turner syndrome. That is the other one. So, or you think about Turner syndrome, or you actually think about an infection of the baby, of the fetus. So, eye drops is very important to localize 2 or more places with fluid. You can call that eye drops. Another cause of eye drops could be the Rh negative. It's called the erythroblastosis fetalis. This is RDMS. I'm not adding more stuff because I like it. Okay, so Rh erythroblastosis fetalis is the incompatibility of Rh negative, positive, and negative from the mother. Eye drops. So eye drops always is a problem. Okay. And here we have an infection. In this case, we are talking about the cytomegalovirus. Tell me one thing, everybody. So, to say bacterial infection is very. I mean, bacterial infection. You can say viral infection, or infection is just for bacteria. Somebody.
No, I think bacteria is an infection, correct?
Yeah, but can you call it a viral infection? A viral infection?
I think they're different, right?
I think both of them are an infection, are the same thing. And usually after a viral infection, patients get bacterial infections.
Okay, so is that some thoughts there? Yes. All right, so listen to this. If you have a bacteria, what is infection? Infection means invasion. Invasion, reproduction, and spreading. So if you don't treat the bacteria, for example, the bacteria is going to multiply about double every 20 minutes. So this is bacterial infection. The virus you can call viral infection, no problem, because the virus are going to invade. Infection invasion. You can call fungal infection, fungal infection. You can call protozoa infection. You can call fungal infection, protozoa infection, parasite infection. Parasite Parasite infection. So why? Because all these organisms, microorganisms, are going to infect, means invade, proliferate, and spread out. Okay, we got it? So here we have any indicator of infection. So infection is not going to be just viruses. It could be any bacteria. It could be the toxoplasm, that is actually protozoa who is going to produce infection. Cytomegalovirus, herpes is going to be an herpetic infection or herpes infection. So that is the way. All right, so here we have, well, I'm not going to divide this in immunological and non-immunological, because the non-immunological is going to be the Turner syndrome. All right, so what is the sign of Turner syndrome in ultrasound? Somebody? Where is the hydrops? Where is it? What is RDMS?
Abdomen.
Around the neck.
Oh, that's ascites. That's ascites. Okay.
Yeah, no, it's okay. It's okay. I like everybody make mistakes. I'm not going to. So always all answers are good. All answer means participation. That's what I want. Okay. Eye drops, you have here the head of the baby in transverse, and you will see that if you go to the, okay, so let's scan the baby and you go in the apex. This is the top of the head. Keep going down. That is going to go, let's put it at the level of the ventricular system. Keep going down. I mean, scanning the transducer, you will see more rounded head. That is for example, let's put it this way, the hypothalamus. If you keep going down, where you're going to get? You're going to get in this picture, smaller, but that is the level of the neck. And what happened? You will see some sac around here with fluid, all this fluid. That is the eye drops in 45X0. Neck fluid located on the neck. Okay. All right, so let's talk about the ventriculum. So is that clear about eye drops?
Mm-hmm.
Yes.
Okay, perfect. Now, who can tell me something about the ventriculomegaly? How much is the normal measurement of the ventricle? What ventricle I'm talking about?
In the head.
Yes, from the head, very well. How much is the ventricle measure? Okay, you need to know that.
I think it should be around 5 millimeters, maybe? Each
No.
ventricle?
No,
6.
no.
10.
Don't forget that, please, okay? Less than 10 millimeters. And you're going to have, here we have, this is the head. Here we have one ventricle. And here we have another ventricle. The ventricle is, this is the nose, this is the occiput, sinciput. The ventricle should be measured here. Not the one who is closer to the transducer, huh? Because there's a lot of reverberation here, a lot of artifacts. So we don't measure the ventricle here. We measure the one who is in the other side, opposite of the, because the lateral ventricles are going to measure, and when it's more than 10, it's going to be called ventriculomegaly. Ventriculomegaly. Be okay with that? Be okay with that? Yes or no?
Mm-hmm.
Okay, don't forget that, please.
Yes.
Okay. Okay. So this ventriculomegaly is going to actually produce a distension of the head, because fluid is going to separate the bones of the head. When that happens, the head is going to look, when you measure the VPD and you measure the the head circumference that are going to give you more dates than should supposed to be. Why? Because the ventriculomegaly, that is the cerebral spinal fluid, accumulate in the ventricle, are going to put pressure and make the head distended. So that's why you need to be careful of that. Okay? Also, cytomegalovirus. And this cytomegalovirus, please don't just try to remember like because of the cytomegalovirus. This hydros, ascites, ventriculomegaly can happen in any infection. In any infection. Viral, parasite, bacterial infection. All right, so we have all right, so we have echogenic bowel, this one, hyperechogenic bowel. So, for example, tell me one thing. Many people say that they say echogenic bowel, but echogenic bowel is not really echogenic bowel. It's more brighter, yes, but is in order to call hyperechoic bowel or echogenic bowel should be as what? This should be intense as white as a bone, very bright, a lot of echo reflection, a lot of echo reflection. So just remember bowel, hyperechoic bowel, or echogenic bowel. We call echogenic bowel, echogenic bowel. Okay, so let's have our 10 minutes break, and we are going to continue. Any questions so far? Questions?
No.
Yes.
No.
Oh, sorry.
Who is this?
Go ahead.
Who is this?
This is Mariam. I have a question.
Mariam, again, let's do it.
When it's in actually ventriculomegaly, so we know that it causes actually hydrocephaly, accumulation of fluid in the basically brain, and also it has some spinal, cause a lot of spinal disorder. My question is, what the spinal disorder actually? What are the example of spinal disorder for ventriculomegaly?
Okay. So tell me, what is hydrocephaly?
Hydrocephaly is accumulation of the fluid basically in the brain that, as you said, it caused the brain to distend.
Is that correct? CSF? Cerebrospinal fluid, right? And
yes.
that is going to cause ventriculomegaly, yes or no? Excellent.
Yes.
Now, when you call, that is very important what you said, huh? How you differentiate if this is just a ventriculomegaly versus an hydrocephaly? How you differentiate is just the ventricles or is the hydrocephaly? Hydrocephaly is the accumulation of CSF in the ventricular system, right? And ventricles is going to be containing CSF too. So how we can differentiate them? You have the answer, Mariam. Can you elaborate a little bit? Let me see.
Because that's actually, it's the spinal fluid, not, it's different than the, that's what I think.
No,
I don't know.
Fluid in the hydrocephaly is CSF. Okay? The fluid in the ventricles is CSF too. Okay? So, okay. But what is the practical thing that we need to look for in order to differentiate them? All right, so ventriculomegaly, you have ventriculomegaly is going to be when the ventricle is more than 10 millimeters, correct? Okay.
That's so, right.
And then you go to the BPD and you do the head circumference, correct?
Oh, yeah? That's correct. If it's distended, it means
normal
actually, yeah.
range. In normal range, that accumulation of fluid in the ventricles is just ventriculomegaly. But if you measure the BPD and the head circumference, and it's giving you in the second trimester more than 2 weeks difference on the dates that you had in the previous, that means that this patient is having hydrocephaly. Is that clear? So what is the key here?
Yes.
The key here is to measure measurements, the ventricle and the BPD and the head circumference. And you know, in the second trimester, the measurements shouldn't be of 2 weeks, less or more. So, but not of more than 2 weeks from the previous ultrasound, correct? So if there is way
That's
off,
correct.
if there is way off, that means that it's actually probably hydrocephaly. Okay. Now,
That's right.
can produce? What can produce the for example, what can produce hydrocephaly? That is the last portion of your question. Hydrocephaly. Hydrocephaly is caused by any obstruction, right, of the ventricular system. It could be in the lateral ventricular system, in the third ventricle, could be in the fourth ventricle, could be in the aqueduct of Sylvius, or it could be when they pass the CSF into the cisterna magna. And we have, for example, Dandy-Walker syndrome that is going to affect the cisterna magna. So they can produce hydrocephaly. Other ones could be any tumors. Especially we have one of the pituitary gland that is out of this scope. It's called the craniopharyngioma. Craniopharyngioma is actually a tumor of the pituitary gland, but the pituitary gland tumor are going to compress the third ventricle, and they actually produce obstruction. The flow of the CSF is going to be blocked, and that start to accumulate. Okay, we got that?
Yes, thank you so much.
Sure.
Thank you.
Okay, so okay, so let's have can we still have about 10 minutes? Yes?
That would be great. Thank you.
Okay, so that took me 4 minutes. That's fine. So let's do 8-6. Okay, hello everyone. Okay, so Tehani, hi. Daniel, Nelofer, are you there? Olan, Lourdes, where is Victor?
Oh, I'm here.
Oh yeah, okay, I see you there. Thank you. And Marian. Good question, Marian.
Oh Lord, I better go.
Okay, so let's continue to our Lourdes is there? Okay, excellent. All right, so let's keep going. Okay, I'm going to. Oh, you cannot see my screen.
There was a break. We follow it like if we were in school. Like they give us a break.
Daniel?
Yes.
So we are over with the break, right? Or 10 minutes. All right, so let's continue. Okay, so here we have the some ventricle here. This is a fetal cytomegalovirus. You see there that actually the tissue is about 38, 39 weeks, because I can see the gyri there. And this is the ventricle, and this is the choroid plexus. Okay, so we have some problems on the ventricular system, dilated. Is that you measure more than 10 millimeters? Okay, let's see. Calcifications. Oh, by the way, another thing that you need to check when you have infections are calcifications. Please don't overlook this. Calcifications can be especially in the liver and the brain. Calcification can be any place on the body. And this calcification means that the patient is having an infection for long data, for a long time. I mean, more than 3 months. Calcifications, don't forget calcifications. All right, so the fetal Intrauterine syndrome. Okay, so in the previous one, we have, that is, we talk about the alcohol, we were talking about pre-AIDS, right? Preeclampsia. So things are common. They're not actually things that uncommon. So we talk about the cytomegalovirus. Now we are going to talk about the Intrauterine. Intrauterine basically are patients who are suffering from seizures. So, for example, that is considered an anti-epileptic drug. So this Intrauterine can produce some problems in the mother and in the fetus. Okay, so here we are going to see that it produce cleft lip or cleft palate. So imagine a woman who has seizures and get pregnant. So what I should do, right? Or stop medication, continue medication. So what you should do? So treatment is to decrease the dose and make environment more feasible for the mother, because seizures, epilepsy can trigger out by noise, by stress, by lights, by different things. So this fetal Intrauterine syndrome can lead into IUER and cleft palate. Okay, microcephaly. So basically, any infection any infection can lead into microcephaly. Differential diagnoses are going to be TORCH, okay, TORCH. Fetal lithium is for these obsessive compulsive disorders. So these people are obsessive compulsive disorders. So basically, they're going to take lithium. There's people around like that, right? Not so few, I would say many. And this lithium can produce what we call the Epstein anomaly. What is the Epstein anomaly in the fetus? Lithium Epstein anomaly. What is the Epstein anomaly? That is cardio. Epstein anomaly. What is Epstein anomaly? Can you see that? Can you see that? What happened here? This is the right, this is the left, this is the atrioventricular, the atrioventricular. So the tricuspid valve is going to be lower than normal. So it's going to be a huge atrium, a big atrium, big atrium. This can produce blue babies at the time of they born. And they can be corrected just to check the annular fibrosis that we talk in cardio, in echocardio. And they are going to change it position here again. Okay, so maternal exposure to the to lithium, the baby can born with Epstein anomaly. Epstein anomaly.
Sorry, doctor, you said it can be corrected. This is Lourdes. It can be corrected by surgery?
Sorry, again, I can't hear you. What?
Sorry, doctor. Can this be corrected by surgical?
Oh, yeah, it can be. It can be, yes. Okay. What they do is wait until they born. If there is SGA, small for gestational age, or intrauterine growth restriction, they wait until they gain weight. I don't know exactly the weight, but definitely, yeah, they need to gain weight in order to increase the survival. It's a risk. Some people, they live with the Epstein anomaly for the rest of their life. And they actually, there is these different categories, levels of severity of the Epstein anomaly. So, all right, so here, I want you to think about a patient with epilepsy. Okay, a patient with obsessive compulsive disorders. Epilepsy, compulsive disorders, infections, like a virus, drugs, alcohol, AIDS, HIV, preeclampsia. So I'm talking about maternal conditions that are going to affect the baby.
I have a question. This is Lourdes. I have a question related to the lithium. Is the toxicity? So the lithium that creates this condition is always an external source, like a poisoning effect, or not? No, it's not the outcome of any metabolic process, correct?
Okay, so what happened here is the lithium is part of what we call the rule of twos. So the lithium is part of those that is like a vancomycin, theophylline, idantoin, and lithium. Lithium is having lithium, the threshold for those is very narrow. For example, Tylenol. Let's put Motrin. Motrin, your threshold of toxicity is this. So that means that there's a big threshold. So you can take a big doses without having toxicity. If you take more than this, they're going to just then have toxicity. But lithium is very narrow. Any small changes on the dose can produce toxic levels. Okay? Okay? So, and the toxic levels, if we do serum laboratory test, And these laboratory tests are going to tell you what is the level of lithium in blood. If you have too much, you need to decrease the dose. Let's talk about Toxoplasma Gondii. So we already talked about that, and this is a protozoa. Okay, and what happened? Basically, I have patients with toxoplasma in the past. Women who get pregnant, basically, they have these malformations, deafness, blindness, and mental retardation. And mostly, they end in early stages with a miscarriage. Where it's coming from the toxoplasmosis, from the transmission from the feces of the cat. Again, you have hydrocephalus, hydrocephaly, microcephaly, intracranial calcifications. Obviously, you're not going to tell this mental retarded the fetus, right? You cannot. Ascites. So what is repeated in all these slides, right? Fluid. That is what I want you to remember. Fluid accumulation. If you have fluid accumulation, could be infections, but could be bacterial, viral, protozoa, could be infections, could be congenital abnormalities. Congenital abnormalities. It could be Rh positive negative. So if you see fluid, could be Turner syndrome here, right? 45X0. So it could be many things. So if you see in two places, two or more, no, don't say, you don't look for three, two or more, that is actually what we call the eye drops. And these eye drops is going to be fluid in any cavity of the body. Hydrocephaly is considered already a fluid accumulation. Ascites is considered already a fluid accumulation. So in order to detect infections or congenital, you need to always see the amount of fluid that should be corresponding to the compartments, no in excess. Valproic acid, this is the grandpapa, the grandmama for all the anti-epileptic drugs. That is being used since the 50s, I guess. Okay, and what is going to happen is going to have IUER, oral cleft, micrognathia, microcephaly again. Heart diseases, mostly we have BSDs. 70% of heart disease problems are going to BSD, ventricular septal defect. Varicella zoster, please don't be scared. Okay, so herpes zoster, that is actually going to lead into infection of the baby. IUER again, IUER. Hepatic foci, that is a calcification. Ventriculomegaly. Okay. This is the liver. Here we have the multiple echoes on the liver. This is an adult, I guess, but it's the only picture I could find. In kids and fetus are going to be like foci, echogenic foci or echogenic foci. Any calcification telling you that it could be an infection. Okay. Oh, really?
Can I ask a question?
Yes. Who is this?
Danielle, when you said in children it's the foci, how come it's not called that in adults?
Hey, calcifications?
Yeah, the calcifications.
No, it's going to be called calcifications. Foci is called, foci is not only for the heart. Foci means localized. foci means is focalized, localized, limited in certain area of calcification. So in adult is not frequent to use to find calcifications. In the liver, we are talking about gallbladder, is different story, but in the liver there is not that common to have those calcifications. I remember they have calcifications when you have Echinococcus granulosus, that is the edatic cyst that basically attack the lungs and the liver. They can produce granulomas that can lead into calcifications. And that case we call foci when it's one echogenic area, a very localized calcification, in other words.
Okay, thank you.
Sure. Any other question, please? Questions? Okay, so I didn't expect that it's going to be so early today to finish. I think we are actually finished our lecture today. I want to be open for questions. Any question?
I have a question.
Who is this?
This is Mariam.
Mariam.
This is Mariam.
Mariam again. Today's your day, Mariam.
Yeah, I just want to know when actually the quiz is going to be available in Canvas.
Tonight.
Okay, thank you so much.
Tonight. Thank you. So we agree, and by the way, we are going to do the review that we have next week is about 6 lectures, correct? It's going to be a lot of effort from everybody, for me too. It's not like a machine. But I'm going to make a summarize preparing you for the midterm. And you, after that, you can take the midterm anytime. You okay with that? Okay.
Yes.
And the last session, you're going to take the final exam. So that means it could be the 12th. The 12th, yes. No, the 12th is Tuesday, I guess, right? Yeah. So the previous one, we are going to do review for final exam. And you can take it until the 12th. Be okay with that?
That is great. Thank you. That's what I was referring to when I was talking about the order of the exams. That is really, really great to be able to do the midterm, not contiguous to the final. Thank you.
No, you can take the midterm and the final the last day of the 12th if you want.
No, my intention is the opposite, is to take the midterm in an organized ahead, not to.
Yeah, I'm trying to give all the liberties to do. In your own pace, and I think we are getting in that. Okay.
Great. Excellent. Thank you so much.
Thank you so much.
Thank you, Marian. Thank you so much. Daniel.
Yes. Thank you.
Okay, Daniel. Thank you so much.
Thank you.
What is Olan? Olan.
Yeah. Thank you so much.
Okay, Mr. Olan. Tahani, thank you so much. We have a good night too. Thank you, everyone. So you can go and have Victor, Mr. Victor. Thank you so much, Victor. Thank you, Victor. And
Professor, take care in the hospital if you are at risk with the patients. I wonder how hard it's becoming, but I'm sure all of us are thinking about that. At the hospital.
Actually, the number of cases are not that severe. I don't. So far, in my surrounding, there is no one with infection. I think that is going to go over soon. There is patients who are really aged people who has preconditions. Those are the ones who are in risk. I have already some people, co-workers, actually nurses who actually have die in that one of those in Santa Clara, in Red Bull City. But definitely, it has come, and things are going to get better. There is a lot of myths right now about the coronavirus, a lot of things, and at the end, I stopped to read everything that is showing in the internet. I just go my work and do what I need to do. Otherwise, I will be psycho already. Thank you so much, everyone, and I will see you next week. If you want to talk to me or have some extra clarification about things, just call me, text me. I'm actually easy for me to text. It's more faster for me. The voicemail is going to take me like 30 seconds to hear and all that, so it better text. Okay? All right, so thank you. Thank you. Have a good night, everyone, and thank you for asking. And please take care of yourself, okay? Be healthy. Be healthy. Keep yourself healthy, everyone. Okay?
Same. Thank you so much. Good night.
Good night. Gracias. Bye.
Thank you so much.
Bye.
Bye. Bye.